prediction. Assalamu alaikum wa rahmatullahi wa barakatuh, جميعا. I'll be talking today about heart failure and single ventricle. It's a very quite rare topic to actually. I have faced a lot of difficulties reviewing this topic because very limited resources and evidence about the management and heart failure, or even the definition of heart failure in a single ventricle. So I'll just go through what exactly is the what is exactly the single ventricle and heart failure in single ventricle. I don't know if you can see my slides very well.
Yes, it's very clear, Doctora.
Yeah. I'll just do a quick review about the mechanism of heart failure. Why do Fontan patients or single ventricle patients have heart failure? And what do we mean by heart failure in single ventricle? Is it different than the classic heart failure in cardiomyopathy or not? And the management options that we have in the literature. So patients with congenital heart disease, those end up with what's called single ventricle, usually have either inadequate development of AV valve or inadequate development of one of the ventricles. Most of them, the majority is right ventricle morphology. Some of them, about 43% of left ventricle morphology. And the rarity of them, 0 to 2%, is indeterminate ventricular morphology. So here is the difference between a normal heart, completely normal heart with a hypoplastic ventricle on the right side and a normal ventricle on the left side. However, the morphology of the ventricle needs to be assessed in the echo. Usually the patients with a complex anatomy, intracardiac, ends up with having a palliative surgical procedures, 3 stages, to be completed eventually with a Fontan. That separates completely the pulmonary circulation from the systemic circulation. So the deoxygenated blood goes to the lungs and oxygenated blood comes back from the pulmonary veins to the left atrium and gets pumped from the systemic ventricle or the single ventricle to the whole body. The single ventricle physiology is a bit different from the other patients with biventricular physiology. Here we say that the lack of subpulmonary pump, that we don't have a right ventricle pumping the blood to the pulmonary circulation. So blood goes to the lungs through gradients, passively to the lungs from the venous return through the Glen or Fontan, which makes the pulmonary blood flow a bit decreased and increases the pulmonary vascular resistance, which affects the preload to the systemic ventricle, making the diastolic dysfunction has an impact there, increasing the end-diastolic pressure, which eventually making a failing Fontan. This is the failing Fontan physiology. The pulmonary vascular resistance also gets higher because of some sort of chronic thromboembolic events that they have. Heart failure in general means that inability of the heart to pump or to pump enough blood to meet the metabolic demands of the body. But in single ventricle is a bit different. Most of the patients in the single ventricle who gets the heart failure and death higher than the others are the one who has the RV morphology. It's due to multiple reasons. Geometry of the RV is different than the LV. The theories are that the RV is not tailored or not created to pump or against systemic circulation at the long term. It's not usually made to face systemic vascular resistance. In single ventricle, we have 2 issues. Either systemic ventricular failure, so the heart itself or the remaining systemic ventricle, it is failing from pump point of view, or there is subpulmonary circulation failure. The systemic ventricle failure, they usually comes with atypical symptoms of the classic heart failure symptoms. They don't come usually with exercise intolerance or shortness of breath or pulmonary edema. They have to be in a very advanced stage to present with this way. And I'll just mention to you why usually they tolerate more symptoms than the other patients. The supplementary circulation, if it failed, we usually say it's a failing fontan. So they present with the lymphatic and venous system failure. They come with protein-losing enteropathy. They come with plastic bronchitis or even liver hepatopathy, liver disease. So just keep this in mind, and we will go back to this slide again. Theories behind the mechanism of heart failure in the single ventricle comes to that ventricular dysfunction can be caused by pressure overload or volume overload during the 3 stages of fontan. It's either due to AV valve regurg or the excess fluid through the Glen or fontan. And sometimes with the pressure overload, they mean the outflow obstruction. Like aortic stenosis or LVOT obstruction or coarctation of aorta. The other possible reason is that, or the other possible mechanism is that the function gets affected with repeated surgery, myocardial injuries, or the myocardial architecture itself is different than the normal. Also, ischemic heart disease. In patients with single ventricle, we all know that some of them comes with the coronary artery abnormality. Those patients, they have some sort of ischemic lesions to their myocardium, which contributes again to the heart failure in those single ventricle patients. And for sure, arrhythmia can play a role in the dysynchrony between the ventricle and the atrium, which can lead to heart failure as well. So the patients with ventricular failure, the systemic ventricle is failing. They don't usually come with the classic symptoms, or they don't usually come as fast as the patients with the cardiomyopathy, because they tolerate a less or an impaired physical exercise due to multiple reasons. They have inadequate cardiac reserve. They have an impaired peak oxygen consumption. So they have inadequate cardiac reserve. They have poor heart rate response to exercise. They have a raised pulmonary pressure upon exercise, poor preconditioning from the baseline, or even sometimes we ourselves as cardiologists, we restrict them from some sort of activity or physical activity. To diagnose heart failure in a single ventricle is really challenging, especially that sometimes patients will come symptomatic with the preserved function. So it's not necessarily to have an impaired muscular contractility and echo to say that this patient is failing or this patient is having a heart failure. So they can come with exercise intolerance, they can come with shortness of breath, they can come with even syncope, but with a normal systemic ventricular function. And the other group is that they are completely asymptomatic. They are living or tolerating the physical activity, but in echo assessment, they have an impaired function for their ventricles. In general, in those two groups, the most important to know when to start the treatment. So 2 main indicators for the treatments are the peak oxygen consumption reduction by 25% in the CPET. In pediatric population, we don't do CPET a lot. We do some sort of a modified test to evaluate the physical activity of the patients, like the 6-minute walk test. It gives us a route, or it gives us like a general conception or understanding of what limitation that this patient is facing. The other indication to start medical therapy or to start intervening with this patient is a 2-fold increase of NT-proBNP during the 6 months follow-up. As every other patients, they have some regular workup, ECG, echo, the advanced imaging, CT and MRI, and I'll let you know why MRI specifically in those patients are quite important. And as I mentioned, CPET and NT-proBNP are quite important here because they are the indicator of starting the treatment. Potential prognostic factors for the patients with congenital heart disease depends on transthoracic cardiography and MRI and the biomarkers as the BNP. And the other one in the BNP here, we have a list of patients or list of investigations specifically for all adult congenital heart disease. Most of them are MRI based. Like we need to know what are the volume index, and diastolic and systolic volume indexes, contractility, mass index, the increase after load. All of those are factors making the patients at a higher morbidity and mortality if those numbers are very bad. So MRI is really important in evaluating those patients. Echo is not enough. CAT, we're not really keen to CAT every patient because all important data about the volume and mass index and the contractility and diastolic assessment can be done by MRI and echo, apart from the diastolic dysfunction and the EDPs specifically. Again, the indications to start the treatment is the peak oxygen consumption and the NT-proBNP. In general, the heart failure management usually, like for all patients, not for Fontan patients, with an ejection fraction less than 40. For the adult congenital patients, if the systemic or the single ventricle is an LV, reduce ejection fraction less than 40, irrespective of the symptoms. If the patient is symptomatic or asymptomatic, we will start treatment if the ejection fraction is less than 40. For the RV morphology, we don't treat unless if he's symptomatic. Those are the guidelines, the recent guidelines. So we have a lot of options for the management: medical therapy, surgical therapy, and surgical therapy includes the mechanical circulatory support and the transplant and other cardiac surgeries like filtration, stenting, extra shunts, and those things. I will not speak about the other cardiac surgeries that can be done to relieve a failing Fontan. It's beyond my objectives, but I will speak about the mechanical circulatory support in the surgical part and the transplant option. For the medical therapy, it's an empiric therapy. There is no, we still lack a lot of evidence supporting specific medication proves that it is preventing heart failure from happening to the single ventricle patients or even improving their outcome in a very good, strong evidence. So all the heart failure, the usual heart failure medication, the renin-angiotensin aldosterone system blocker, beta blocker, mineralocorticoid, diuretics, SGLT2 inhibitors, and then Entresto. A lot of researchers have been talking about those medical therapy in Fontan circulation. There is a very nice review done by Part and his group for the current option, published in 2022, and another one published in 2021, speaking about the Entresto and talking about the promising effect of the Entresto. Currently, there is an ongoing clinical trial in California studying the DAPA, infantile circulation. So diuretics are recommended to be used only extensively in symptomatic patients, although that there is no strong evidence again. Spiro was not found to have any strong effect on the endothelial function or even altering the serum cytokines like the other cardiomyopathy patients. Like we know that spironolactone had a strong evidence in cardiomyopathy patients in remodeling, but it was not found to have the same effect in single ventricle patients. Although that the evidence of beta blocker and ACE inhibitors are not quite not with or without, actually they are conflicting. Some of the studies will say that you use ACE inhibitor and beta blocker with caution because it might, they might even depress the ventricular filling and might increase the right to left shunt, which makes, if there is a fenestration of the Fontan, and makes your patient more cyanosed. So Entresto is still promising, but there is still no strong evidence in single ventricle or Fontan patient, but we usually tend to start Entresto in young teens. Even in the adult population, it's well studied in the cardiomyopathy, but not strongly studied in the adult congenital diseases. Milrinol is a very is a very good for short-term effects, but it's not for long-term. Some of the hospital has established a home Mirrinone therapy, but I think it's still, none has done it here. A program worth trying if we can just try to build a home Mirrinone therapy for some of our patients, decreasing the hospitalization and some comorbidities and infectious issues that can happen during hospitalization. It carries their own risk as well. SGLT2 inhibitor, DABA is not known in pediatric a lot. Again, we started in early teens, like 13, 14, patients with a good size body build that we can start DABA in. In single ventricle, there is no published data until now, but there is an ongoing clinical trial in the UCLA Medical Center. Those all are our medical options. Surgical options, apart from whatever possible cardiac surgery can fix the cause of the failing fontan there. If there is no other cardiac option, we know that mechanical circulatory support nowadays has been doing like a lot of good survival rate and actually relieving a lot of patients from their complications, bridging them even to transplant. In mechanical circulatory support, we should know what is our goal exactly and what we are treating. Is it a destination therapy that we are not able to proceed more than this? So we tend to get to more of heart mates, not Berlin heart or pulsatile VAD in general. Or are we bridging to cure? We can use ECMO for 14 days or up to 1 month maybe. And mechanical circulatory support always has the higher risk of bleeding, strokes, and infection, and a lot of other issues. Or bridge to transplant, which we all hope when we put a patient on mechanical circulatory support. In mechanical circulatory support, we need to know what to pick exactly. Which kind of mechanical circulatory support? Are we putting LVAD, like a VAD for the systemic ventricle? Or are we supporting the systemic ventricle, or are we supporting the fontan circulation? Or are we supporting both? And where to hook exactly? Where to hook, I mean, where to put the cannula, the inflow and outflow cannula. This has quite complex surgical challenges, but needs to be very tailored very well with the advanced heart failure specialist and the surgical team. There is an overview was done by Jacob Miller and his colleagues in 2018, which showed, just let me I just want to minimize this one. Yeah, which was done in, which was releasing studying the survival in hospital discharges of single ventricle who required mechanical circulatory support. They found that 30 to 50% of the patients of single ventricle underwent mechanical circulatory support over 25 period in a single institution. 33% survived 2 hospital discharge. So either they end up with a destination therapy or a heart mate or bridging to transplant, but at least they reach the hospital discharge. And when they studied the kid in patient database, they analyzed the patients who were in ECMO and analyzed more than 700 patients over 10 years, found that the survival rate was more than 40%, and the outcome did not improve over the decade evaluated. Some of the patients who required ECMO had poor outcome, even worse than other congenital heart disease. Patients with end organ dysfunction prior to mechanical circulatory support had poor outcome, which brings me that before deciding that this patient should go to VAD or should go for a mechanical circulatory support, like a bunch of investigation should be done. We should involve cardiopulmonary evaluation, advanced imaging, EP should be involved, CAT should be involved, liver evaluation, kidney evaluation, even hematology, because some of the VAD patients can develop during the VAD itself, the VAD state, they can develop some sort of deficiencies in coagulation factor, which makes them more prone to bleeding or thrombosis. So this is what I mean when I say what to pick and where to hook. What do you mean? Do you need a pulsatile flow or a continuous flow? What's exactly the problem of the physiology of the failing fontan now? Is it a systemic ventricular failure? If it's a systemic ventricular failure, there is no point of badding the fontan. If the pressures in the fontan are good and we are not having an issue with like protein-losing enteropathy, plastic bronchitis, we're not facing a venous congestion in the liver, there is no point of connecting another Berlin heart or another VAD on the fontan circulation. So it's enough to have only a systemic circulation support, an LVAD. We usually call it an LVAD, but it's not an LVAD. It's a ventricular assisted device, whether it's left or right. Or is the systemic ventricular function is good. And by giving like inotropic support or doing an LVAD will not benefit this patient if he has a protein-losing enteropathy and the issue is with the pressures inside the fontan, or you have a fontan obstruction and you could have made a stent and that's it. Or do we really need dual support for both of them? Those other options in the bottom here are the continuous flow, and those they can go with those VAD or heart mates to be discharged home. And the one up here, they usually have to stay in the hospital, connected to a Berlin heart to pump their support. Back to this slide. So this is what I mean when I spoke to the previous one. So we know that systemic ventricular failure or failing pump, they're not actually white and black. The patients can come with both of those phenotypes, and they have mixed outcomes. So if I have a failing fontan or a high pressure in fontan, I wouldn't benefit again. I would not benefit from VADing the systemic ventricle. I need to support the fontan circulation. It's not the ventricle, which I need to support. So we need here to cut the patients to know exactly what's the end pressure, the diastolic pressure for those ventricle. The patients with less than 12 millimeter mercury or many dysfunction, placing a VAD will not help them. So we need to focus a lot about the fontan itself, not the systemic ventricle. On the other side, like this is a case scenario of one patient, 5-year-old girl had a fontan with completely normal systolic function of the ventricle, had a severe plastic bronchitis and routine-losing enteropathy, was ventilator dependent, inotropic dependent, had to be on ECMO. At that stage, that patient was not a candidate for transplant. She was not even candidate for listing. So the team invested in that patient and put a cardiopulmonary VAD insertion. Only the fontan circulation was supported with a VAD or with a Berlin heart. She stayed in that VAD for 588 days. Her protein-losing enteropathy and plastic bronchitis completely resolved. And she was transformed from a patient who's not candidate for a transplant to a patient with had a successful heart transplantation. Those are the promising cases that gives us like the courage or the desire to go for a mechanical circulatory support in a failing fontan or a patient with fontan circulation. The heart transplantation and fontan or a failing single ventricle is the ultimate treatment. Like if we know that this patient if he was listed today, he will get a heart tomorrow. This is the ultimate goal without going to mechanical circulatory support, without going through all this possible complication pre and post-operative. The first-year survival in post-transplant fontan patients was reported in multiple studies to be 85 to 95%, and 10 years survival is 80 to 90%. This is a study was done by Dr. Bundy and his group in 2016. They studied the patient who underwent transplantation between 1973 until 2012, which showed a survival of 80% post 1 year and 55% survival after 15 years. In another study by Dr. Simpson and his group in 2017 showed significantly improvement of the survival rate between the early era and the late era. The early era in 1 year, survival was 77, and in the late era was 89%. And more recently, in 2021, around 700 transplanted patients in 18 articles was reviewed by Dr. Haruki and his group, showed that the immediate survival was 88% and more than 10 years survival were 61%. Most of those patients had pre-existing Fontan-related comorbidities like protein-losing enteropathy, plastic bronchitis, or even heart failure, or even arrhythmia. They were not found actually to be, a single one of them was not found to be directly associated with a greater risk. However, some of, like, if they have two or more, those factors were contributing in a relative risk of 1.94. More recently published this month by Dr. Kurt and his group, they reviewed, or they had done a retrospective cohort study, involved 20 centers in United States and Canada. They studied only the Fontan patients who were listed for heart transplantation from 2008 until 2022. There were more than 400 patients. 5.9% of them died while waiting on the waiting list. 83.4% who underwent to the transplant, 8.5% who did not survive to the first year. So only 27 patients from those patients who got transplanted died before the first year of their transplant. They mentioned that the risk factors for their mortality patients on the waiting list were related to higher aortopulmonary collaterals burden, more hospitalization during the previous year prior to the listing. They were younger in age, and they had sleep apnea, which definitely affected the pulmonary circulation. They had higher NYHA class. They weren't going to school or the kids or even work as an adult, or they have a single parent at home. The risk factor for those who died in the first year included hypoplastic left heart syndrome, tend to die more than the other congenital heart disease with Fontan circulation, patent fenestration in the Fontan circulation, anatomic Fontan obstruction, clinical cyanosis with a pulse oximetry less than 90%, polycythemia, portopharyngeal disease, mental health condition requiring treatment, and higher HLA class 2 panel reactive antibody, which means sensitization. They had antibodies. Those patients with cardiac disease who end up with conduit or patches, they tend to develop some sort of antibodies, make them more sensitized, and have less options to find a proper match when we want to transplant them. The patients who survived the first year of their heart transplantation, the independent risk factor were more than one hospitalization the first year before the waiting list, and clinical cyanosis. Though those were the most important risk factors for mortality. That's all about the heart failure in single ventricle. I hope that I answered a lot of questions for you.
Thank you, Dr. Asseel. بارك الله فيك.